Good morning, everyone. It's a pleasure for me to stay here in this webinar at CITIC 2019 in Mexico City. I am Dr. Jaime Mulo from Sinaloa, Mexico. I'm an interventional cardiologist, and it's an honor for me to introduce Dr. Mamas Mamas. Dr. Mamas Mamas is an interventional cardiologist at Akili University, honorary professor at University of Manchester, and is a kind of rock star of Twitter and Radial expert. So this is a webinar about transradial access. It's an honor for me. Thank you for your kind disposition, Dr. Mamas.
Oh, Jaime, the honor is mine. Thank you to you for organizing this and for the conference organizers for inviting me to this great meeting. I'm very excited to be in Mexico. I think it's a fantastic meeting, and I'm grateful to Terumo for sponsoring this webinar.
Thank you. The first thing we would like to know is comparing radial access versus femoral access. What are the major or the main advantage from radial access?
So there have been a large number of randomized controlled trials, observational studies that have really focused around the benefits of transradial approach, particularly in high-risk populations, those undergoing PCI for ACS and particularly STEMI indications. What these studies have shown is that transradial approach is associated with a reduction in access site-related major bleeding complications, and this translates to a reduction in MACE and mortality in these patients at high risk from these events. And that's why the European Society of Cardiology recommends the radial approach in this patient population as a Class 1A indication. We also know that there's other benefits for patients, so benefits including early mobilization, a reduction in embolization of arthromatous plaques, therefore protecting renal function in these procedures, and also a health economic benefit. So data from my group has suggested that adoption of the transradial approach in the United Kingdom has probably saved £20 million. So that's a huge saving over the 5 years since radial approach has become the predominant radial access. I think the final thing to think about when talking about the radial approach is overwhelmingly that there's huge amounts of data. Every single national data set that has been published has shown a benefit of radial.
As we know, we can imagine different factors to disadvantage of radial access. But one very important issue is when we move from femoral access and get this transition to radial access, about the evolution of the dedicated devices.
Yes.
Can you tell us about something about this?
So I think this is a very important question. I think the first thing to say is that the patients most likely to benefit from the radial approach, those at high risk of bleeding complications, so the very elderly, the patients with complex PCI that require large bore catheter access, are often the patients less likely to receive radial. And really there's been a need for the progression and development of equipment. And this has really happened in a number of ways. So for example, the introduction of thinner sheaths. So for example, there's glide sheath slender from Terumo, which saves a French size compared to conventional Cs. This has really helped us deliver the transradial approach in patients that are going to benefit, i.e. patients with small radial arteries, such as the very elderly, ladies, and also patients that undergo complex PCI, so those patients that require 7 French. There have also been other developments, so for example, the importance of radial-specific catheters, so Tiger catheters, Kimine catheters, Ikari catheters and so forth, that have really facilitated use of the transradial access site. Also developments of techniques, we shouldn't forget things like balloon-assisted tracking that helps us go up very tortuous radials where otherwise we would have given up and gone femorally. We've completely changed our understanding of patent hemostasis, for example, and hemostatic devices in radial. So, for example, Terumo make a number of these devices, such as the TR band. And again, learning how to use this with patent hemostasis preserves the radial approach for future procedures, because we know that these patients will go on and on having future procedures over their lifetime.
Exactly. Yes. So over the time, we do more and more radial access in everyday, more complex patients. For example, we have a little concern about STEMI patients or very cheap, the classic cheap patients with radial access, and some centers around the world have this concern about use radial access in this very complex scenario like STEMI, for example.
Yes, I would say that that is somewhat misguided. We know that STEMI patients are at the highest risk of bleeding complications, so they're exactly the patients that should have radial access. A number of trials have shown superiority in the STEMI population. Interestingly, the Safari STEMI trial presented recently at the ACC suggests that perhaps that there isn't a benefit in this population, although one mustn't forget that this trial was flawed in that it was discontinued because of the fact that it was underpowered, so the 30-day mortality rates were 1.5%, which suggests that it was a very low-risk population. And even though it was a low-risk population, the conversion from femoral to radial was around 8%. And so the manuscript hasn't been published yet, but it'll be interesting to see whether the access site bleeds in the radial group were in fact femoral bleeds, similar to the rival analysis. And also there was a very high use of intra-aortic balloon pumps in this use in a very low-risk population. So again, that may contribute to perhaps the lack of difference. And it was an underpowered trial, and I don't think we should read too much into it. Even taking the Safari STEMI trial into consideration, recent meta-analyses have shown a consistent benefit of radial over femoral in STEMI cases. And that's why, as I mentioned earlier, international societies still advocate radial as the safest approach in these patients. We know that the radial approach in experienced hands doesn't add significantly to procedure time or door-to-balloon time. And I would say that if you're doing STEMI cases, you should go radial. If you're not experienced, then I think it's important maybe to start your experience in elective cases, more straightforward cases, and then transition through to STEMI cases.
Yes, probably very nice information about those practitioners in the early time to select the correct way the patients to start with radial access. So an interesting data recently reported comparing the SAFE guide, ultrasound guide, femoral access versus radial access is a new information. What do you think about this result?
I mean, I would always advocate if you have to use femoral access, and we do. I'm not against femoral access. I'm a TAVR operator. We use femoral access for TAVR, and I think the gold standard care should be safe femoral, so should be ultrasound access. I think looking at the data of ultrasound guided versus femoral versus conventional radial, we still need a good, adequately powered randomized controlled trial. Don't forget that the SAFE PCI analysis comparing radial versus safe femoral, which showed no difference in outcomes, was a post hoc analysis. So you have selection bias, you have a bias. And the SAFE PCI was a low-risk population. A lot of the patients there underwent diagnostic cardiac catheterization. And so I would still say that the benefit of radial is there, irrespective of whether you use an ultrasound probe or not in getting access. And don't forget, a lot of the benefit is early mobilization of patients. Whether you use an ultrasound probe or not is irrelevant. Patients will still mobilize earlier. There's a smaller risk for embolization of arthromatous material from the aorta, contributing to renal function deterioration. Whether you use an ultrasound probe or not is irrelevant. You will still have that, particularly in patients with chronic renal failure or impairment of renal function. So I think safe femoral is important. We have to advocate it, but radial first still.
Yeah, I agree with that. So finally, the final question. Is there some contraindication, on your opinion, to use radial access?
I would say that the obvious contraindication is a patient with no arms.
Yeah.
I think patients with connective tissue disorder, such as Sjogren's and so forth, I've had bad experience with those. So in those cases, I probably would go femorally. I think otherwise the contraindications are very low. I mean, I think the patients at highest risk of bleeding complications are those that are known to gain most benefit. So radial first always.
It's difficult to find contraindication, as you can see.
Yes.
So it was a pleasure for me. We thank Terumo for their support for this webinar. We will hope to enjoy CITIC 2019. And
Yes.
It's a pleasure for me. Thank you very much,
Thank
Dr.
you.
Mamas.
Pleasure. Great.